Yes, doctor. It's fine.
Been very long since we last had a session, but I believe you've been having sessions with my other colleagues. I remember we had done the biology, congenital anomalies of GIT. So I want us to look at also look at the stomach. Right?
Yes.
Who is the second class captain apart from Patricia? Or Vijay, the class captain? Communicate to the others so that we can start. Can you communicate to the others so that we can start? Somebody reported that I'm low. Can you now hear me well? Can you now hear me well?
Yes, doctor, but your voice is breaking. I don't know if network's disturbing. It's on and off.
Most probably network. Can you hear me now? Okay. Can you communicate to the others so that we can start? Is it okay now? Yes, we can see Patricia. Who's the other class captain?
It's Marvin.
Marvin. Is he here? Okay, fine. I believe since we have both half the number of class, the rest will get us. Do you hear me well?
Yes, we hear you.
Okay, fine. So, Marvin, last session, we talked about the stomach and what to start the smallest intestine, the rest of the gut, small intestine, large intestine.
Yes, doctor.
Okay. Are there any questions from the previous lectures, or somewhere where anybody did not understand and wants a recap?
Yes, doctor, I have a question. Hello?
I assume silence means there are no questions from the past. I can pick up from here and continue. Okay, so let's use an hedgehog. Okay, let's continue. So small intestine consists of the duodenum, jejunum, and ileum. So it's that of portion of the foregut and then midgut. Okay, remember GIT system is divided into three: foregut, midgut, and hindgut. And foregut ends at the second portion, second part of the duodenum. Midgut starts from the second portion of the duodenum halfway up to the proximal third of the transverse colon. Then the hindgut starts from of the distal two thirds of the transverse colon, descending colon, and sigmoid. Then rectum and anus and canal. So you find that small intestines will consist of that portion of the foregut and then mainly midgut. We talked about the rotations, if you remember. We talked about the malrotations. If you remember, okay. Michel's diverticulum, the physiological hernia, then omphalocele, and gastroschisis. Those are congenital abnormalities which occur with during the process, the time of development. Now, small intestine consists of duodenum, jejunum, and ileum. Small. Now, it measures between 18 to 21 feet. Okay, in adults. Let's say approximately about 3 meters in an adult. Obviously, there can be some variations. Not everybody may measure up to 3 meters, but on average, let's say about 21 feet. Okay, and when you change it, it may be uh, it may be what? It may be about 3 meters. Now, in the physiology, you'll know the function of small intestine is mainly reabsorption of digested food. A little bit of digestion still occurs, especially in the duodenum and portion of the jejunum, where you have secretions from the pancreas and the bile. Okay, being released into the second portion of the duodenum. Now, it's still attached to the posterior abdominal wall by long mesoneum, most portions of the small intestine. But that can also be a disadvantage because it can easily be avulsed off. Avulsing can mean either torn off the posterior abdominal wall in events of acceleration, deceleration, forms of injury. Okay. Now, the linings of the small intestine, as we shall see in coming lectures when you look at histology, is the stomach with so mainly long, whose main function is mainly churning to either mechanically break down food. Within the small intestines, we have mucosal walls, which are circular, referred to as plica circulare. Okay. Now, in the duodenum, you find that the first part, or the superior part, does not have this plica circulare. You find it mainly in the second, third, and fourth portions. Then the rest of the small intestine. So duodenum, as you see in this image, it is shaped. Okay, it continues from the pylorus here, continuation of the stomach, and it crosses over to the right, over the body of crosses over to the right into the hepatic flexure here, and bends downwards to form the second portion of the duodenum, which runs over the medial end of the right kidney. You see the kidney posterior there, and then it turns still at 90 degrees to cross over the body of vertebra T12, and it crosses anteriorly to inferior vena cava over there, and the abdominal aorta there, and then the fourth portion of the duodenum. Now, this C-shaped appearance encloses medial to it the head of the pancreas, as you see in the image here. So you have the head of the pancreas here, and then the tail of the pancreas is near the height of the spleen. Now, over the third portion of the duodenum, the inferior part, you have the superior edge, you have the superior mesenteric vessels, okay, running above it over there. And at the end of the fourth portion of the duodenum, which is the ascending part, you have fibers or connective tissue fibers, which may have some bit of muscle or skeletal muscle called ligamentum of trees or suspension ligament. That marks the end of the fourth portion and the beginning of the jejunum. So it marks the duodenojejunal junction. And its function mainly is to keep that junction patent, allow empty of contents. So this duodenum here, yes, it's divided into four portions. Superior, which is the first part, second part is descending, the third part is the horizontal, the fourth part is ascending. Its length is about 25 centimeters, which is about 10 inches. The different parts have particular lengths. In inches, you can, the first part is 2, the second part is 3, the third is 4, and then the fourth part is 1 inch. You can convert to centimeters, which is 5, 7.5, 10, and 2.5. So basically, you find that this first portion lies over vertebra 2, not 12. Okay. The first part lies over lumbar vertebra 1, and then the third portion crosses lumbar vertebra 3. Sorry about what I said earlier on. Now, like I told you earlier on, the first portion of the duodenum mainly is dilated and relatively has smooth wall, does not have plica. This is a common site for duodenal ulcers because it's one place where it receives mainly the gastric contents, and it's a place where alkalization of gastric contents starts. Hello? Can somebody please turn off your mics? The second portion, which is the descending part, has two main openings, which is the common opening of the opening of the bile duct and the main pancreatic duct at the hepatopancreatic papillae or ovata. But you also have a small opening which is proximal to this ampulla ovata opening, which is the accessory, and usually for the small accessory duct, as we see in the next image here. So this is the major duodenal opening you see here, and the bile duct and the main pancreatic fuse and open as one into the second portion of the duodenum. You may have a small duodenal papillae, which is not constant in position, and it is opening of the accessory pancreatic duct of Santorini. Though in some people it may not be there, others may be there, and the positions is not constant. But for the major duodenal papillae, it's constant. Okay. Now, in this image here, portion of the duodenum is smooth, and there are no circular folds like we see in the second, third, and fourth portions. And with ulcers, and we easily have perforations, most commonly in this portion. That means medially to the second and superior to that portion, you find the head of the pancreas here. Now this means that a patient who has cancer of the head of pancreas, cancer of the head of pancreas and pancreatic duct. That means drainage of this bile duct of bile through the common bile duct is hindered. And patients present with jaundice. So this is the obstructive jaundice as a result of pressure on one caused by the cancer on the head of the pancreas. Okay. Yes. So can we continue? Now, in this image, just a minute. Okay, we can continue. Now, so that means that our foregut ends around halfway here. Okay, it involves the first portion of the duodenum and then the second portion, the upper half of the second portion. The lower half is now from midgut. That means that even blood supply to this portion, to the duodenum, it will receive blood supply from. Please, can we turn off our mic? Those who are joining us, please turn off your mic. Timothy, can you turn off your mic? My God. Okay, let's continue. Please turn off the mics because anyhow, let's continue. So you find that blood supply to the duodenum receives from portions or supplies the midgut, which is the superior mesenteric, giving contributions to as this anterior, posterior, inferior pancreatic duodenum, and then the upper portion here, which gets from the anterior, posterior, superior pancreatic duodenum, which comes as branches from the celiac trunk. That is for upper portion. Okay. Yeah. The fourth portion, yes, we said crosses to the left of the aorta, abdominal aorta. Now, the duodenojejunal junction is not like you get a continuation. You don't have a clear line which says the junction is here. Okay, it's not like a corner, but we have the ligament of trees to guide us to point to where the junction is between the duodenum and the jejunum. But also, when you see in slide number 6, it's a continuous, the mucosa is continuous, and yes, there's a bend there, but if you look at the mucosa, you don't have any clear line change between the mucosa and the fourth part and what we see in the jejunum. Though it's a uniform and a gradual change at that junction. Okay. Now, most importantly, we can have duodenal recesses. These are spaces which can be found okay, paraduodenal space to the left of the duodenojejunal flexure. Peritoneum. These horizontal folds may be lifted off the posterior wall, and then you end up with space behind them. And this can cause, let's say, an internal hernia. And I believe most of you thought hernias are what you see outwards. The inguinal hernia, umbilical hernia, you can see it. But there are also internal hernias. And once I was operating a patient, we opened the abdomen, and there were no small boil loops. There was hardly any small boil. The internals couldn't believe and was asking me, Doctor, where is this person's intestines? Okay. But all of it had gone into the paraduodenal recess. And they were obstructed inside there. They couldn't get out. So the patient had an internal hernia, and had not intervened, probably it would have become ischemic and would have lost most of his small intestine. So we reduced the intestine, we removed it from that pocket, and we reduced the defect, we repaired the defect such that his intestines will not go back into that pocket, into the paraduodenal recess. But we needed to be careful because one of the boundaries of the opening has the inferior mesenteric vessels. So if you aggressively try to occlude the defect, you'd end up tying the vessels which supply the midgut, and therefore the patient will not benefit. Huh? So let's go to the next image here. We still get to see the suspensory ligament of trays. It gets fibers from the right cruise of the diaphragm, and its main function is to hold open and to hold open such that the duodenojejunal junction contents can flow out. Okay. Blood supply to the duodenum already which is derived from the lower gut, gets branches from arising from the celiac trunk, and then the lower half, which is derived from midgut, gets branches deriving from the superior mesenteric artery. Yeah, okay. So this image shows you can see here inferior mesenteric, and you can see the celiac trunk there. And then the branches, you have the common, you have the pancreaticoduodenal, anterior posterior, supplying this medial end, and the other side you have anterior posterior but superior. Lower end is inferior. That means whichever procedure in future somebody wants to do on the duodenum, maybe there's a puncture you want to repair, or there is a mass you want to remove, we should try as much as possible to avoid the medial end, because the blood supply to the duodenum, it arises on the medial end compared to the lateral surface, the antimesenteric, the lateral surface. So your operations, your incisions, your resections should be done mainly on the lateral surface, because if you do that on the medial, you end up cutting off supply, which comes on the medial surface, which is running on that area between the head of the pancreas and the duodenum, and you get branches supplying the duodenum from there. This image here is important. One time I operated a patient who swallowed a toothpick, playing with toothpick in the mouth. Those of you eat and you want to keep toothpick in the mouth for all of us to know in that toothpick. So this 13-year-old boy swallowed the toothpick, but when it reached the second portion of the duodenum, it couldn't maneuver through. So it punctured. It went through the walls of the duodenum around this area, and we found it here in the hepatic flexure. So I removed the toothpick and then repaired the perforation, and he recovered and went back home. Shows that this corner here is tight. That there are for some people who swallow things, others swallow bones, others swallow coins, others swallow nails for whichever reason. Some will go around this bend. There's a picture of some child who swallowed the hook of mosquito net. And luckily for that patient, he managed to go through all these corners, these tight corners, and so it managed to go through the corners. And by the time we came to hospital at good regional referral, was now in the rectum. So we only observed that one. The hook in the stool, the patient disappeared from hospital thereafter. But we managed to see the hook. I'll look for the image and put it in this slide before I send to you. Then there was another one, I think I gave you the picture when we were in class sometime back. Over exchange, always keep it away from children. So the bracelet, one of patients ran away from hospital. So shouldn't surprise you. You learn that patients, when they recover, They just pack their things and leave. So that one is, we call them run away, that the patient took off. Okay. It's a term we use to mean patients who have run out, who have left. But let's take it seriously. Caveras may not see them on image, but it's also not good to swallow cavera because it can cause an obstruction. There are some people, especially who have psychosis. They may swallow cutlery, spoons, forks. Others go ahead to swallow even table knives. So in your practice, you need to have an open mind. You'll meet interesting cases. I also manage the patient to swallow the toothbrush, nice toothbrush. I believe I told you. For for that woman, it failed to go beyond the what? It goes beyond the what? It failed to go beyond the pyloric orifice. So the toothbrush remained with the stomach. And then we didn't have endoscopy. The endoscope spoiled, so we did operation and removed the toothbrush. An article is online, so you can Google and you see it. Please let's be serious. The some of the chat on is not for serious people. How can somebody swallow a plate? Okay, maybe pieces of metal objects. Some want to commit suicide, but I want you to appreciate that whatever objects that patient swallows, you have narrow points where the object to maneuver. Some might remain in the stomach because they cannot go across the pyloric orifice to enter the duodenum, so they remain in the stomach. Others, they may enter the duodenum, but they cannot make the turns from the first portion to the second portion. So they perforate the wall of the first second portion and they end up in the hepatic flexure. Are we together? Okay. Yeah, basically that. And some are round, so they'll go through the whole system until it gets out. There are those who swallow coins, some young children who swallow coins. Sometimes it gets lodged in the esophagus, especially at the areas, the areas of constriction, at the upper esophageal sphincter, at the sternal angle of Louis, where you have the bifurcation of the aorta, or can obstruct at the lower esophageal sphincter. Once it passes those portions, we observe the patient. We ask the parent to keep checking the patient's stool because it may through the system without. Because coins have round edges, it will go through. But those who swallow nails, we need to actively monitor them because they can perforate the walls and they end up with the what? They end up with perforation and nail in the peritoneal cavity. There is also an image of a child who swallowed a pin. I'll still look for that image, put it in this slide. Now, for the pin, it was now being actively monitored because at the time they took the image, they didn't know whether the pin is within the boil loops, within the lumen of boil, or is in the peritoneal cavity. So there they observe to see signs of peritonitis. If peritonitis starts, that means probably the pin has perforated the walls of the lumen, the walls of the gut, and is in the peritoneal cavity. That means it needs to have operation or laparoscopy, and they remove the pin. So for those who like swallowing objects, be careful. It may cause after the duodenal junction continues as jejunum. This one now is attached still to the posterior abdominal wall by the long mesentery. In the neonate, portions of the duodenum is free within the cavity, but in adulthood, you find that portions of the duodenum are plastered against the posterior abdominal wall. Actually, the portions of the duodenum is retroperitoneal, except portions of the first portion and the fourth portion. Now is within the cavity is intraperitoneal, held posteriorly by the thumb by the mesentery. Please turn off your mic. This man was that. Can you hello? Can this man? Okay, thank you. So this is how when you open the abdomen of that cadaver, this is what you'll find. How it looks like intact bowel, uh, with the greater omentum removed. So you have the transverse colon lying just superiorly, and then the loops of small intestine. The jejunum is mainly superior, and then the rest of the intestine lies there, continues down into the pelvis. We can have the ascending colon with the cecum down here. The ascending colon and sigmoid is on the left and is covered up by the loops, except when there's pathology, obstruction down, and there's distension. It can distend right up to, it can distend superiorly. So there are some characteristic changes. The term is has thicker walls and more vascular than ileum. So it has thicker walls and more vascular than what we see in the ileum. But in physiology, you learn so much absorption occurs in the jejunum, and certain substances are reabsorbed within the jejunum. So when you're looking at the physiology, you should be keen on that. Okay. Then the blood supply to the ileum and jejunum. Still, you have the blood branches of the superior mesentery arching in the mesentery, and then you get these branches called vasa recti running through the mesentery to give branches onto the portions of the jejunum, and also here to give portions to the ileum. But you can see the arrangement, it's different from what we see in the jejunum up here. You have the vasa recti, which are longer in jejunum than in the ileum, with the arterial arcades are simple, 1 to 2 in jejunum compared to what we see in what in the ileum. Now this is significant because the time will come we may need to resect portions of the lumen of the small intestine, like in this, if this part which has been opened, let's say this patient had probably gunshot injury or stab wound and needs to resect. You are going to cut this portion of the lumen, but also you need to be careful to hold mesentery because you may cut the arterial arches and end up cutting off blood supply to rest to the other portions of the ileum we should have wanted to save. So as you resect, you shouldn't cut so deep, like up to the end of this one layer of the mesentery which was removed. This is not good because you may end up cutting supply to the rest of the. You end up cutting supply to the rest of the what? To the other portions of the duodenum of the resect and anastomosis. This resection and anastomosis is a common operation in surgery. Okay. We need to be careful not to injure the mesentery because that is where the blood supply is from. So you keep as much as possible to the bowel loops and resect that portion, not to tamper so much with the mesentery. There are those who are aggressive, they end up cutting deep into the mesentery and injure the arterial arcades. Some might even resect the superior mesentery or inferior mesentery. Now, if you cut and tie the mesentery down the other side, that means you've rendered whole portion, which is supplied whole portion of the intestine, of the gut, which is supplied by that vessel. So, in future, you need to be careful. And if you're assisting somebody, you still remind them to be careful not to cut the mesentery so deep. They'll end up cutting off supply to the rest of the other structures. Okay. This image is a simple diagram which shows us supply to the foregut, midgut, and hindgut. This we already talked about it. And this shows us before the rotations have happened. And also we already talked about the rotations. So midgut is mainly supplied by superior mesenteric, hindgut is by inferior mesenteric, and it extends up to the rectum and anal canal. So there's nothing new there. You're going to have some branches, but they form anastomosis or arcades, which are into the mesentery. And then they give the straight branches, which are the vasa recta. Now, now the superior mesenteric may have branches, especially for the transverse colon, ascending colon, and also for the iliac. Like let's see in this image here. This is the superior mesenteric. It has branches. You have the jejunal branch there. You have the colic there, right colic, and then the mid colic, which is going to supply portions of the transverse colon. Okay, as you can see there, this forms anastomosis. Yes, there's no problem. But if for some reason you want to resect bowel, and you end up tying and cutting the superior mesenteric, let's say even before it gives off the right colic artery, you can imagine all this other portion of the bowel loop that you would have cut off supply to. They will come necrotic, ischemic, and necrotic. So that one, yes, the patient had disease, but now what you've caused is worse than what the patient had. So the patient will lose most of that bowel. So please be careful as you perform any procedures in future. Okay. Yeah. This is still the image of the superior mesenteric. We shall appreciate it better as we dissect, probably when we resume. So you find that you have the anterior mesenteric portion, but within the mesenteric surface, that's where you have your blood supply from. So care needs to be taken. And also, once you resect, you should make sure you tie the blood vessels. Otherwise, the patient will bleed. Remember, superior mesenteric is a big vessel coming right from the abdominal aorta. Any small bleeder, any vessel which is not tied will obviously bleed a lot. And by the time you take notice, the patient will bleed all the blood into the peritoneal cavity. That is why any injury within the abdominal cavity should be taken seriously. A penetrating abdominal injury, you have to open and see what is inside. Either open or laparoscopic, but you need to visualize, see that the mesenteries are not injured, the bowels are not injured. Okay, that one will come in future. Please, if you have a penetrating abdominal injury and you're an intern, don't just keep quiet on that patient and you put theater lists on the Monday because it's a Friday evening and this your senior is not around. Make sure you reach your senior so that you help that patient. Your patient may not be alive on Monday as you planned. Venous drainage follows the arteries. Okay. The laparoscopy is done in Uganda, especially around in Mulago. And they say Nakasero case, but it's more expensive than open surgery. Even Rwanda does laparoscopic surgery. You make keyholes, you make keyhole incision, and then a camera is inserted, and instruments are inserted through those holes. Then you visualize on screen as you manipulate, as you operate. So it's there in Uganda, but it's expensive. With small bowel, you have naturally there are constrictions, areas of narrow points where, like I said, foreign bodies can get lodged and obstruct. The junction of the pylorus and duodenum, the duodenojejunal flexure, and the ileocecal orifice. So these are portions where foreign bodies can get lodged and it causes mechanical obstruction. Some of you who chew mirror should be careful because in future you may end up having mechanical obstruction. There are some people with the psychiatric conditions and they like eating or swallowing hair. This Fidel man should put off his mic. Okay. So those who have psychiatric conditions and they eat or swallow hair, this hair can form a ball inside and cause obstruction. Some people can have worms, okay, ascaris lumbricus, can be so much that they form a ball. So I've seen some who can have up to 1 kilogram or have between a kilogram to 1 kilogram of worms in their lumen or in the gut and cause obstruction. I don't have the video, but I believe when you check online, you'll see some of those videos where worms are removed from people's small guts and causes this obstruction. Now let's talk about large intestine. Now, large intestine has unique characteristics when you compare to small intestine. Small intestine, you have the muscle, the both smooth muscles, longitudinal and circular muscles are uniformly distributed, as you see in this slide here. The circular muscles and longitudinal muscles are uniformly distributed, which makes the surface of the appearance to be smooth, uniform, and then the serosa is all looking nice. When you compare to large intestine, you see that you have ulcerations on the walls of the large intestine. And then you have 3 points where you have longitudinal muscles which are congregated on the anterior, on the posterior, on the lateral surface. Okay, and these are called the tinea coli. So this makes it different, unique compared to small intestine. If you compare the large intestine on the left and the small intestine here, you see that it looks different. Don't think of size, because in the event that there's obstruction, this small intestine may become dilated, almost the size of this large gut. Size alone is not enough to differentiate between small intestine and large intestine. Okay. Sometimes you may find that the large intestines have shrunk for whichever pathology, and it's even small, almost the size of the small gut. So don't look at size to differentiate these two, but look at the unique features on the surface, the ulcerations, the tinea coli, and for large intestine, you have fat aggregated on the surface, omental appendices, or appendices epiploica. You see, you have these fats which are found on the surfaces of the large intestine. This also helps us to differentiate portions. This is not found on the it's not found on the rectum. We have seen people, or we have seen stories of people who, in the name of resecting the appendix, resect small intestine. Others resect fallopian tube. So we need to be careful. Or you, as an assistant, you need to advise the person who is doing surgery. If you think that is not appendix, you can tell the person politely, first again, okay? Show me the cecum. If you say show me the cecum, that will click in the person's head that what? You want to know, okay? Maybe it's not the appendix that the person is having, or you've picked a wrong tissue. So Marvin doesn't know what a fallopian tube is. Yes, the last time a nurse advised the doctor they chased her, it is true, but you may find the doctor just embarrassed to accept that he was doing a mistake and the nurse could have right and didn't want to swallow. Medicine has a way of humbling people. Those who do BTL also, please. This man here, please advise those who are joining to turn off their mics, okay? We have also seen that those who BTL as a way of family planning have also ever cut small intestine in the name of cutting the tubes and dividing. So please, if the nurse asks you, doctor, are you sure that is the one? You be humble enough to cross check, because she's going to be the one to save you. If you do a mistake, the nurses are the first people to go around to start saying that doctor doesn't know what he's doing. It's the nurse who will tell the attendants what the mistake the doctor did. It's not the doctor. And before you know it, the attendants are already on your neck. So please, appendicitis is inflammation of the appendix, Either you have something obstructing it, maybe stones, maybe worms, maybe mucus plug, maybe even feces. Okay, but it's possible that it can perforate and you have appendicular abscess. It may perforate and then you have even stool into this right iliac fossa. So when you reach the clinical years, you continue with that discussion of how to manage appendicitis, how to identify it. Now you should know that the appendix is found at the point where the inferior portion of the cecum, at that portion where the three tinea coli, that is where the base of the appendix arises. It's a blind ending tube which does not play much function in the digestion. So even if they do appendicectomy and remove the appendix, it will not affect your function. Okay, it will not affect your performance or function. Obviously, unless they made mistakes during the surgery and have complications of the surgery. So the different parts of the large gut have cecum, appendix. Told you it's a this part is not developed. We don't use it. We don't need it. But until it gets disease, then you get to operate it. If it's not diseased, you leave it. Okay. You have the colon, which is the ascending, transverse, descending, sigmoid, and then the rectum and anal canal. The cecum still is the active part, the initial part. It's a blind ending pouch, and mainly it's found in the right iliac fossa. But because of development, rotation, depend on, you can have malrotation and end up having the cecum arrested, found around the hepatic area, or even found anywhere within the abdominal cavity, or even the left. Those are disorders of rotation. Probably the patient had malrotation. So, like here, you have a high standing cecum. Yeah. Now you have a valve at the ileocecal junction here, which prevents contents of the colon of large intestine from going back into the ileum. The appendix here opens into the cecum down there. The position of the appendix may vary. You have one which is within the iliac fossa. You have one which is retrocecal. You may have one which is long, goes into the pelvic cavity. You may have one which goes behind the terminal portion of the ileum. Now, that one which goes into the pelvis proper, we need to be careful because we may think somebody may confuse to be either ectopic or pelvic inflammatory disease. Because when you examine the vagina, you elicit tenderness, cervical tenderness, just because appendix is long and is going deep into the pelvis. So you need to be careful in the future and differentiate. So when you reach the clinical years, you should ask the surgeons to give you more detail on how to differentiate these appendicitis. So it is attached. This vermic appendix is attached between around 2.5 centimeters inferior to the ileocecal junction. Okay. It has a small mesentery, mesoappendix, which has the appendicular artery running through. And once somebody is doing surgery, is to tie that vessel or ligature it, otherwise it will bleed and cause significant blood loss to the patient, anemia. Yes, like I said, some can be retrocecal, others can be lying over the pelvic brim, and the rest may just lie in any other position. For those who have abnormal rotation, you may have appendix on the left. Have you heard that? If somebody, if a patient had a malrotation, it is possible for the appendix to be on the left with the cecum and the ascending colon. Okay, that whole combination can be on the left, and therefore you can have tenderness on the left iliac fossa, not the right. So you should not say that it can never happen on the left. It can happen on the left if there is abnormal rotation. Right together. These are the different portions of the large colon, as you can see here. Ascending and transverse. Now, in this case, we have the greater omentum removed. And we say the greater omentum is like police of the abdominal cavity. Wherever the infection, it goes there to try to occlude, close up or arrest the infection and limit it around that area. I have seen the number of operations, those who have perforation of the appendix, you find greater omentum comes and tries to fill up or occlude that perforation or arrest the perforation around that area so that the rest of the intestine or peritoneal cavity is not contaminated. Sometimes we use this greater omentum in repairing perforation in the duodenum. We can use just a minute. We can use the omentum if we have a perforation around here, first portion. Emmanuel, this Felix man. Yes, Emmanuel, what's your question?
Yeah, good afternoon, Doctor. No, good
Yes,
afternoon,
I
Doctor.
can hear you. Yes.
Actually, you were talking of the great momentum being the policeman of the abdomen. And now I was looking at how it happens when it because I'm questioning myself if there is maybe an inflammation somewhere in the abdominal cavity, in the abdominal cavity, and the great momentum has to intervene. Does it close up that part or that cover that part that is claimed by a physical mechanism, or it takes time to develop up to that extent where the inflammation happens?
Let's say,
Or it is by physical.
okay, let's say the greater omentum is like a sheet. A towel. You know how a towel is?
Yeah.
You can move a towel whichever direction you want, not so. So if let's say there's a perforation in the appendix, the lower portions of the greater omentum, you find it around that area, covering the area where there is perforation, such that it limits infection. The greater omentum within itself has lymphatic tissues, okay? Within itself has lymphatic tissues which help to fight infection, okay? Can somebody help us with this Felix man? If he can't mute, we may need to remove him. Can you send a message to Felix? Tell him to mute. If he can't mute, then we shall. Felix mind if he cannot mute this thing. It's just that I don't see the option for muting from here. It is Dennis to bother with the gods. Okay, let's continue. Please, let's advise Felix. Can somebody call Felix and tell him that his noise is probably the problem was coming. Let's continue. Just leave it. He's even attending to class. Felix, are you with? Felix, okay, thank you. So I was telling you that the greater momentum can be used even if we when we're doing operations and you want to secure the area very well, we can mobilize the momentum. I'll show you when we're doing during the lessons. We can move the momentum and put it, we call Graham's patch. We call that Graham's patch. You can watch a video on YouTube. You go Graham's patch or perforation repair, and they'll show you clearly how momentum can be used to repair a patch. Are you together? YouTube, and you type Graham's patch repair or modified Graham's or perforated PUD repair. You see the video and it shows you how momentum can be used to repair defects within the intestine. Even momentum, we can use it to repair patches anywhere in the perforation. You can put it there, and it helps. It can help arrest leaks. That. Okay. So the appendix here, many positions, as you can see, some are retrocecal. There are times you open and you can't see the appendix. Don't close. Don't see the anatomy has changed. Look for it. Try to elevate the cecum. You'll find the appendix. As long as if you get the cecum, identify the intestine, the small intestine. Look for the campiculum, point where it joins the ascending colon. Inferior to that junction is where the cecum is. Obviously, we get difficult surgeries. Recently, I had a difficult one. Probably the patient had perforation, had its previous operations. There's a lot of adhesions. The cecum was pulled to the right. Okay, so it was not easy identifying the cecum and the appendix. And in my head, I was like, should any of these ones in my class be here may see me sweating and wonder if they'll just see me sweating. Definitely, I had to first look up to where the hepatic flexure is, identify the ascending colon, come down. That's when I was able to identify the cecum. It had been pulled towards the left. After releasing the adhesions, then yeah, it now came out clearly. So most times people do anything in the abdomen and they never, because it's not in surface, they don't know what happens. So whoever goes there is the one who suffers. So, but you need to have the basics right. You need to know that you have the descending colon. Need to know that the appendix is at the base or at the lower portion of the cecum. Once you have that, then wherever the cecum is, you need to look for the cecum, and then you'll identify the appendix. Obviously, there are some cases when you the abdominal cavity like this, the appendix, the tip of the appendix will be looking at you. There, you don't need to even look for the cecum because you may displace the portion. You just pick the appendix and then you look for the base. And within 15 minutes, you're closing the skin. Okay? So you just have to keep this base in your head as you to help you later in life. Definitely for those who are going to do public health, yes, you will need to keep this information to pass the exam. When you're doing your public health, you can forget these things. Okay? Yeah. But it's important. Your clinical anatomy, applied anatomy is important for surgery. Otherwise, people are you're going to catch a lot of wrong things. You had sleep, my friend. This guy is serious. He should just apologize and not talk about it. I think we need to have discussions such that people can participate actively. Because if you're going to sleep off like Felix, then it is actually I'm very annoyed with Felix. But for now, let's leave it like that. So this man here, it's Maweje. Since it's afternoon, he should leave the lecture. And Benon, stop making fun. Let's concentrate. I don't know if you people have appreciated the appendix. Do you have any question? Can somebody ask something or make a comment? Patricia? Patricia?
Yes, Doctor. May I have a question?
Yes, you can ask your question. Hey, Patricia, you have a question. Can you ask it?
No, Doctor was like, I have no question.
Marvin? Marvin?
Yes, doctor.
Yes, do you have a question?
Doctor, they normally talk of appendicitis being a common condition that is found in males. I was just trying to think about it and why it is so, but I failed to find
now
I don't know whether you could do.
in this class. Is it Felix? I need to learn how to remove some of this. Can somebody call Danish and tell him to make it, please? No, let's stop here. Since the people are not here, we shall start from here later. Probably we shall share dates. Please, if you are coming joining the class, turn off your mic. These things irritate. You know, after using this thing, you should have known this by now. Do you need to be reminded? Let's stop here. I've gotten let's stop here. We shall start from here next time. Okay. Thank you.